start by saying thank you very much to Africa Advocacy Foundation and MyCare for organizing this series of meetings and trainings. Can I say that I wouldn't call myself an expert in advocacy. I think we found ourselves in the team from Cyprus to have some successes that are worth sharing and building our collective skills and support, collective support and solidarity between us, community organizations. So I'll go through two cases that we had that were successful, and then present a quick toolbox that I've put together based on other organization trainings on advocacy that I attended. I think one of them was from Africa Advocacy Foundation as well. And I found them really interesting and really helpful for taking this knowledge and implementing it into the context in Cyprus. I'll start by saying that my name is Christos. Excuse my pronunciation. It's a foreigner's English pronunciation. I hope you understand me. I'm currently the chair of the board of AIDS Solidarity Movement, but I've been a volunteer in the organization since 2014. In 2015, we started the checkpoint, the Cyprus checkpoint that is providing anonymous, rapid and free STI, HIV and STI testing in Cyprus. And last year we started the PrEP point. I've also been involved with AIDS Action Europe Steering Committee and Cobates Network Steering Committee. I'm a member of the European AIDS Treatment Group. And we've been working with AAF since the network was created through the first round and the second round, and we are really happy to be partners with AAF. And I have no conflict of interest. Now, I'll start directly with the first case study that came to us in 2022. It had to do with a student in Cyprus who was found through the compulsory tests that students, international students have to go through when they're studying in the Republic of Cyprus. He was found HIV positive, and he came to us in December 2021. We received a Facebook message asking our support because the university had told the student that they had to leave the country because of the HIV status. And at that point, that was what the message was saying. There was no reference to anything that had to do with migration laws or anything else. So what we did initially was to meet with the students. So we met in our office and try to understand the case, what exactly happened. It looks like the student had to go through these tests, and when the university found out that the test was positive, they wanted to, they asked basically the student to leave. So it was not an official deportation. The student was positive. They knew their status, they were on treatment, and they were also undetectable. Let me at this point say that in the Republic of Cyprus, there is a law that says that if someone is not a Republic of Cyprus citizen, they are deported if they are found to be positive for HIV. But this does not apply to anybody who is a European citizen. So there is a discrimination already where students who are international students, or let's say non-national students, if they are EU citizens, they can stay in Cyprus, study in Cyprus, even have access to the free monitoring and treatment for HIV, but not for students who are not coming from the European Union. And I think that Cyprus is one of the few countries in the European Union that still has this kind of laws. So we discussed internally of what we could do. We thought that this was a really difficult case because we would go basically in a way against the legal framework, the existing legal framework, although we thought that this is completely absurd, to still have this kind of laws in place. So we decided on a strategy, and then we called the student back to discuss the strategy. So the strategy was we needed to have a written consent from the student that we could potentially use his identity in case that the ministry was asking us of proof, but we would not put it out publicly. We would also try to avoid giving information like that, but we would be very difficult because part of the strategy was, the second point was to delay the deportation. So the idea was to ask from the university and the migration to not deport the student on the basis that they knew they are HIV positive, they are on treatment, they get the treatment from their country. The treatment was suppressed to undetectable viral levels, and that meant that this person could not transmit the virus. And also on the basis that other international students in Cyprus that are EU citizens with the same exact HIV status are allowed to stay in Cyprus. Now, let me make a point here that somebody being undetectable should not be or being detectable, and thus to be able to transmit the virus should still not be discriminated against. And we had a huge discussion about that because we felt that it was another level of discrimination between the detectable and undetectable people living with HIV. Because, HIV is not COVID. It's not a public threat if somebody is positive and detectable, because basically the virus has very specific ways of being transmitted, and we all know that. So we kind of used the U equals U argument with half heart, I would say, because on the one hand, we thought that this is what language the officials would understand and accept, but at the same time, we agreed that we were going to put that out in public if necessary to make sure that you don't have to be undetectable to be somebody who is not a public threat, especially when the very high percentage of transmission in Cyprus and Western Europe is basically, I think it's more than 95%. The transmission is through consensual sexual intercourse. So that means that people can also use condoms. So the third point in the strategy was to send a letter to the HIV reference clinic in Cyprus and to the Ministry of Health, asking them to provide an official letter that the student was indeed undetectable, so we could use that proof coming from the authorities in Cyprus. So we did not want to stay only with the tests that the student had from their country, but also have something local that would legitimize, let's say, the status of the virus in the student's body, and use it to ask the migration and the university to refrain from deporting the students. And then a longer strategy, something that will be very difficult to change, was to change the law. It takes years to do that. It's really difficult. It has to go through the government, through the parliament, reforming the legal framework of a country is not something that could happen in a couple of months. So we first decided to try and change the decision of the deportation and the decision of the university that at that point had told the students. This is the paper that we got, a confirmation that the student was undetectable. We actually wrote the wording because the initial wording that we got was very stigmatizing, and we told the doctor that provided the initial letter that, if this would go out publicly, we were not going to put it out publicly, but if it was going out publicly, that would expose the clinic because of the stigmatizing language. And we proposed a different language which was adapted. So that was the first level. And then we put together a letter. These all happened in the same month, in December, so we acted quite fast. To ask, this is the letter going to the ministry, no, to the migration department, actually. We were putting out the information that this student should be allowed to study. And I want to make sure that you notice that we had the references, the evidence-based references of what it means for somebody to be undetectable. And something unexpected happened. We were waiting. The student continued their studies from December after we sent that letter. We never received a reply. And then on the 16th of March, a couple of months later, the student got a letter saying that from the Ministry of Internal Affairs and the Migration Department that they had to leave Cyprus. So this was a bit unexpected because we never received any reply to our letter. So this kind of changed the strategy, and we had to change the strategy. And I had to say that when we found out, it was a day before a public holiday where we had a 3 days, Fridays and a weekend coming up. And we were like, what are we going to do in 3 days, when this is coming out just before the holidays? So we decided that we are going to go ahead anyway and put out a public call out of a discrimination based on HIV status in Cyprus. So we talked to the student. We agreed together with the student that we were going to do that without mentioning their name. And we put out a call to the local media and international organizations and other bodies. I'll show you in a bit. Basically, calling out that the Ministry of the Department of Migration was discriminating based on the HIV status. And again, we had all the references and the evidence-based data on that letter. And on purpose, what we did when we changed the strategy, which was an emergency in the sense that we felt that the student had to kind of leave in a couple of days or weeks, so we didn't have time. So what we did was to put out this call that the state was discriminating against an HIV positive student. And we put it out in local media, newspapers, TV channels, radio stations. We sent it to the Ministry of Health. We sent it to the Ministry of Interior. We sent it to the House of the Parliament, the representatives, which is the Parliament, also to the two committees, the Health Committee and the Human Rights Committee at the Parliament. We also sent it to the European AIDS Treatment Group and AIDS Action Europe, two networks that we are working with, and we are closely working together, asking that they provide us their support in case it was needed. And we also send it out to the commissioners of the EU commissioners of equality and the Commissioner of Health, Food and Safety. And we publicized in the letter that we were going to put that letter out to all of these. So anybody who was receiving the letter knew that this is going to go to all of these places. And we did that on purpose because we wanted the local media to know that we were going to put it out in the public sphere, but not only locally. So what happened is on the 26th of March, 2 days later, the internet started putting out the press release saying that the student is going to be deported because of discrimination, that the AIDS Solidarity Movement is publicly complaining. And it was quite the media adopted what we put out. We even had some local TV and radio stations asking us to speak about it, and we went. This is the Cyprus Broadcasting Corporation, the state channel that spent some time for their central news of the day, and we even had an article written that basically advocated that if this case went to the European Court of Law, what would this mean for a state like Cyprus that claims that has its human rights violated by Turkey, and it's violating human rights itself. So it was this is something that came out without us expecting it, to be honest. We got a reply later on from the Ombudsman office and a reply from the European Commission. And we were invited later on to the House of Parliament to discuss about the topic. In 3 days, we had heard from the news that the minister announced that they changed their decision of the migration department, and the student would be allowed to continue their studies as long as their health was monitored and at the HIV reference clinic, covering their own cost. And the student had to go and take a viral load test every 6 months, once per semester, paying an amount of about 200 euros. So before I go into the second case, I will go a bit deeper on how we worked to do that when I go into the advocacy toolkit later on. I just want to give you the facts for the 2 cases first, and explain a bit more into details on how we worked on that. I have to say before starting the case study too, that when we put the public call out that the state was discriminating against these students, we didn't believe that we would be successful. We got the consent of the student to do so in a last effort to do something, knowing that chances were that we were not be successful. The minister announcement 2 days after we put that out was a shock for us, a very, very pleasant shock, a great news that came out that we did not expect that this would happen. Now, I'll move into the second case study, which is the advocacy for official access to PrEP. I'll put that also out on the table, and we can discuss further when we go in the plenary in this session. We started advocating for the official access to PrEP in Cyprus in 2018. First, we went and we attended some conferences, the PrEP in Europe Summit, that was in 2018. We decided that it was really important for us to be able to advocate for official access to PrEP, to run a survey so we could have evidence-based data that PrEP already existed in Cyprus, but it was basically informal PrEP. It was PrEP that was not going through official channels of distribution, rather than people buying it online or from the north side of Cyprus, which is the areas in Cyprus that are not controlled by the Republic of Cyprus. For those who don't know, Cyprus has a de facto division. There is a northern part and a southern part. The Republic of Cyprus is controlling only the southern part, but we can cross, and European citizens and Cypriot citizens can cross to both parts. And since the Turkish invasion in 1974, there is this de facto division. But we do have cooperation with organizations, with community organizations in the north, and we have people crossing from the north to the south and using our services as well. So it was apparent from the very beginning that anything that had to do with PrEP should be created, the plan for official access should be created in a way that would exclude nobody, as much as possible, because that would be a problem if we had a program that was excluding people. So we came back to Cyprus after the PrEP in Europe summit, and we decided to partner with Accept, the LGBTQI organization running in the south side, and we got some money from ILGA Europe to run the survey. We ran the survey, and we managed to have some documentation of official results from the research that we also partnered with the Professor Nikolopoulos, an epidemiologist professor in the University of Cyprus, who helped us to do the analysis of the data. And we started doing public speaking about PrEP, educating people what PrEP is, and also in public media, but also at the checkpoint when people were coming to get tested. And we did present the results of the survey and the results from data of the checkpoint community data at the AIDS conference we had in Greece. So we could further legitimize basically the data that we had, that PrEP was already here, and the ministry was, and the state was letting people use a preventive treatment on their own risk, instead of providing support and making PrEP official. In 2019, we had a conference. We actually had the nerve to request funding from the ministry to cover the expenses of the conference, and we got the funding, and we invited the ministry and the a WHO Europe representative to present the best practices around PrEP, and we presented the results of the survey in Cyprus, and we also participated in the second PrEP in Europe summit that took place at the time. Excuse me. And we continued to advocate publicly for PrEP. Nothing was happening until 2024. So for 5 years, nothing was happening in terms of actually being heard. We had a lot of promises and politicians telling us how important PrEP is and trying to push for it, but nothing was actually happening. But we did continue to speak about it. These are from the meeting that we had at the House of Parliament and the research, and doing work again with the public media, talking about PrEP in an inclusive way, how this is a preventive measure that should be available for everybody. It is not for specific populations. We should not stigmatize people who are using PrEP. We should look at PrEP just like a condom use. So, if people go and use condoms, we would not stigmatize them, but we would say, that this is a responsible decision to protect their health by using a condom. So PrEP was the same thing, and it was the only thing that was missing. And then in 2024, the National AIDS Committee was restarted. It had stopped for a couple of years, and it was the COVID years, let me remind you. So all the intention was shifted basically from other health issues and moved into COVID, so as if there was only COVID at that period. And in 2024, we had the National Committee restarting, where we proposed that we should have a plan that the National Committee should approve to submit to the ministry in regards to the official access for PrEP. And we stepped forward and suggested that we could write the plan and bring it to the National AIDS Committee. And they accepted that we could write the plan. We wrote the plan, we submitted it to the National AIDS Committee. There were a lot of discussions because the plan that we wrote was inclusive for everybody. There was no criteria. exclusion criteria for who should not have access to it. And again, in order to be able to do that, we based our plan on previous plans. And we also did a bit of digging and found out that WHO actually suggests that PrEP should be available to everybody without any exclusion criteria. And we used it as a recommendation. And we did not only stay up to that, we actually asked WHO Europe to provide a letter of recommendation for these suggestions, these guidelines, especially for Cyprus, which we submitted together with the plan. So it was not just a plan that we wrote, but we had support from WHO Europe, basically supporting the arguments that the plan was providing. So the plan was had a provision that PrEP should be free, should have should be accessible by anybody, should not be tied to the national health system, because if it was tied to the national health system, that would mean that for somebody to access it, they would have to be registered in the health system. And that this would also support the STI strategy of the ministry, because through PrEP, the populations who have access to PrEP are taking tests every 3 months and every 6 months, and that would actually help the ministry to map the statistics of the STI epidemiology and prevalence in Cyprus, something that is a non-existent. In 2025, the plan was submitted to the minister from 2024, and in early 2025, we were informed that the minister approved it exactly as the National Committee submitted it, which was the exact plan that we basically submitted to the National Committee. And again, we just found out internally that the minister had approved it. There was no official announcement. Nobody knew that the plan was approved by the minister apart from the members of the National AIDS Committee. So we thought that, this, in order for it to be implemented, it's great that the minister approved it, but that's not enough, because if it's just approved, it could stay for a couple of years in some drawer at the ministry. So we decided to go ahead and launch the Cyprus PrEP Point, which is basically doing, and we announced that it was going to be doing what we already were doing to support people who want to have access to PrEP in a way that the community can, especially for populations that don't have easy access to healthcare. And we went ahead with the launch in May, and we invited the ministry to come and present the plan that was approved by the minister. In order to do that, again, we did not do that alone. We reached out to the local and international community. We asked AIDS Action Europe and European AIDS Treatment Group to endorse our efforts with the Cyprus PrEP Point, and we actually asked them to and convince them to send us a pre-recorded message from their executive coordinator and director, the executive coordinator of AIDS Action Europe and director of EATG, endorsing basically the launch of the Cyprus PrEP Point. And also we turned to local organizations like the Cyprus Family Planning Association, the IPPF member here, the Cyprus Refugee Council, Accept, Queer Cyprus, and we put it out there that this was going to be an official launch. We invited media. We made sure that we had a camera of our own as well, so we could capture the presentation that we were going to be doing in terms of what the PrEP Point is, and also with the announcement by the minister or the representative of the ministry that would present the plan that was approved. This was the representative of the ministry, the head of the HIV reference clinic, who came and presented the plan. And in that meeting, we presented also the messages from EATG and the AAE. And the video, we subtitled it in English and Greek, and we put it out there like in less than a month. So this would go out into the public sphere, that the PrEP plan was officially approved with specific characteristics, and then we could be able to publicly speak about it. And we followed it up with a series of press releases, basically announcing that this was going ahead in Cyprus and we would have PrEP, and we were expecting the ministry to tell us when. Again, nothing was happening. Let me remind you that it was May, it was the Pride month. So we decided that we should not wait further. We should still push now that as we say in Greek, the iron is still hot. And we decided to put together a series of webinars. So we declared June the PrEP month, the month for PrEP. And we asked from 8 organizations and representatives to present topics around PrEP. The first one was with George Nikolopoulos, the professor that helped us initially with the plan, with the survey, and later on at the National AIDS Committee, he also helped us with the suggestion that we wrote. Then we asked Dr. Mameladzis, who is a PrEP expert,
Monsieur Nguea Jean-Paul. Je constate.
Nolwazi, can you help us a bit?
Yes, Christos. Sorry, Jean-Paul, is there something that you're saying, or it was a mistake?
Yes. So do we need a clarification? I'm happy to do so.
Jean-Paul, do you have a question? Okay, I think he just forgotten to mute. You can carry on, Christos. Okay. Yeah.
So we put together this PrEP month with 4 presentations. So you'll see that we had the WHO expert, Dr. Mameladzis. We had an epidemiologist, Dr. Alon Ellenbogen from the University of Nicosia. We had AIDS Action Europe presenting their work around prevention. We had WHO Europe presenting their guidelines. The same thing goes with ECDC. So it was Dr. Grankov, if I'm saying that correctly, from WHO, and Taimur Nouri from ECDC. We also invited the Positive Voice Greece because they just had the rollout of PrEP in May, end of May in Greece, and we thought it would be interesting to see how that was going. And we also had a presentation in the as part of the core, the community response to end inequalities European funded program, together with the EATG, and we presented the cases of Cyprus and Ukraine. So we basically reached out to these people and asked them to take part in the PrEP month, and we made it easier for them, asking them to choose any date that was suitable for them in the month of June, and that we would be putting this together as a PrEP month, and we would be making these seminars available later on for people who would want to know more about PrEP. So to cut a long story short, we basically wanted to put out that the plan that was approved had 3 phases, starting from 2 cities in Cyprus, expanding in the second phase after a year to all the districts of Cyprus, districts controlled by the Republic of Cyprus in the south. And the third phase that would come 3 years later would go through the personal doctors, the family doctors and pharmacies. So we wanted to put that out so in a way we could publicly have the ministry commit that this plan would be implemented as it was approved. So 3 months later, in October, we just found out, the ministry just informed us that they were rolling out PrEP in October and they wanted to have a meeting with us so we could have a discussion on how we could support them in this rollout. And it was great because basically now we have officially, since October, we have PrEP officially rolling out in Cyprus with that plan. We are in the first phase, and the Cyprus PrEP point is now officially supporting the access to PrEP with consultation and empowerment, and we even accompany people who need to be accompanied, who ask us to for somebody to be with them when they visit the hospitals, especially when it comes to populations, key populations like migrants, even undocumented migrants, people who engage in chemsex, people who are sex workers. So we basically don't need to be an intermediate. Somebody can directly go to the clinics, the PrEP clinics at the two hospitals in Larnaca and in Nicosia. But if somebody needs more information to decide if PrEP is for them, and if they need support for someone with from us, from our team at the Solidarity Movement and the PrEP Point to go together with them, and we had cases like that, it's making the lives of especially migrants easier. It's helping with making the communication easier, and it can be quite chaotic for people who want to have access to PrEP to visit a hospital by themselves, find where they have to register, where they are going to see the doctor, where they have to go and take the tests. So the whole process is made easier for people who the system is more hostile to them. We did not do this alone, obviously. As you can see, we again engaged with all these people, and I will go directly into the toolkit. And at the same time, I will give you a few more information aligning the toolkit with how we worked in these two cases. Although let me say that this happened the other way around. The toolkit was created based on how we worked. So what is advocacy? Advocacy can be defined as the act of publicly recommending or supporting a particular cause or calling attention to an issue or a problem, and we advocate to recommend change. Now, we should all follow some steps before we begin the advocacy. The first thing is that we need to identify a specific problem or an issue that we want to address. Then we need to find the possible solutions that we want to advocate for that problem. So we need to have some kind of a suggested solutions, and obviously they have to be realistic. But by realistic, I don't mean that they have to be solutions that the state thinks can take place. Because when we were asking for PrEP, for example, and we said that it should be free, it should be accessible to anybody, there should be no criteria, exclusion criteria. In other countries, PrEP is accessible only for MSM, men who have sex with men, or specific populations. We were asking that, and we said that PrEP should be available to anybody who asks for it. And the solution was realistic because we did two things. We basically said that if it's not the case that everybody can access it, and it's just MSM, then who is willing to go and declare themselves officially as a man who have sex with men to have access to PrEP? This is actually a barrier instead of a facilitating access. And the second really important part is that the people who need PrEP the most would not identify necessarily as men who have sex with men, whether they were having sex with men or they were not. So it should not have a criteria, because it would exclude the people that would actually benefit from PrEP. And the third point was that WHO actually recommends that it has no criteria. Let me just make a small asterisk here. The criteria, the existing criteria is there, but it excludes nobody. So the criteria is like, everybody who is asking, who chooses to ask PrEP, or any cis or trans man, any cis or trans woman, any person engaging in substance use, any person who is offering sex work. So there are criteria, but they are written in a way that they exclude nobody. Then you have to decide on what the outcome is. So there is a problem, there are specific solutions that you want to suggest, but you need to have a very specific and clear outcome of what you want to achieve. And then you need to map your support. In general, we did not do things in a way that we were as if we were doing them alone. We tried to identify, reach out, and find allies, supporters, partners who would stand beside us. Even if we were leading an effort, we would always have other organizations, community organizations, and if possible, not only local, to basically say that we are not alone in this. So it's really important to do this mapping. I'll go into it a bit later. Identifying also expected obstacles, opposite arguments, possible dangers, and get prepared on how to address and answer to these arguments that are the opposite arguments, or the people who are saying no, there should be criteria for this and this reason. For example, for any problem there are arguments used against yours. You need to know them, and you need to have a strategy on how to address them and how to basically void them. And then you need to put a strategy together, a strategy in the sense of a specific action plan with a timeline. Then you need to follow it. So you need to implement the strategy. And the last is that you need to be able to and be ready to adjust the strategy if it's needed or when it's needed. Like we did, for example, with the case of the student, that we had a strategy that we would not go publicly with calling out the ministry. We would ask diplomatically the ministries and the migration department to allow the student on the basis of their viral load being undetectable, and we were kind of forced to go publicly because of the unexpected deportation claim that came out in March. So the goal should be realistic, but it should be smart. It should be specific, measurable, actionable, realistic, and time-bound. Now, the levels of action, you don't always need to go publicly with things. I have to say that the culture of our organization is that we usually go with a more diplomatic way. We try to work with the state. We try to work with anybody who we are asking for change from. But in order to do so, you need to always have the first level of action, become a professional in what you're doing, research the best practices out there, check what is working elsewhere, apply to your local contexts and see what could apply and what could not apply, and adjust it. Get positive examples, get evidence-based information, work with and speak with numbers and statistics. And if you don't have them, you need to produce them by, for example, creating a survey or running an online questionnaire. Be careful, because in a lot of countries there are rules to run the survey or research, from biomedical committees. So that's again another part that it's important to partner with academia and provide some eligible, let's say, data analysts and academics to help your work if you don't have any in your team. We don't, so that's how we found people that we are working close together to get some help from. Constructive criticism, obviously. So this is something that we did a lot internally, especially with PrEP. We had to first also convince ourselves that PrEP is good for us, because in the beginning, the arguments that, if PrEP is out there, then we are going to have a rise on other sexual transmitted infections. This argument was valid, and it's true. When you have a rollout of PrEP, there is a period where people engaging in PrEP, using PrEP, are engaging in condomless sex, and there is a possibility to have STIs increased. But there is a counter argument that, through PrEP, you can actually find these infections, treat them, monitor them, and actually the PrEP is a great tool to manage other STIs as well. And of course, calling out the best version of oneself, I put it in the first action because I think it's good to always reflect and inspire your partners and allies and people you work with of the causes of why we want to do this, and what does that mean in the sense of changing the societies that we live for the better. Then there is the second part, the getting uncomfortable, which is the calling out, basically, the seeking responsibility, diplomatic criticism, or using knowledge as a weapon, or pushing for accountability. In the case of the migrant student, we put out a public complaint, and it went out not only locally, and that's why I think it became viral. In the case of PrEP, we made the official launch of the PrEP point, especially to put out publicly the plan. So it was a way to ask for and seek for responsibility and accountability that the plan would be implemented. And the way you do things, the last section I have there with the call out, it's not necessarily that you always need to use it, but you should not be afraid to use it if it comes to that. Naming and shaming, saying that this happened with this data, with these people involved, especially if they hold positions that they should be accountable for what they are doing. And I have to say that that letter to the ministry that was never replied to when we sent it to the Ministry of Interior and the Migration Department. It was addressed to the head of the Migration Department. We never got a reply from. And the head of the Migration Department came at the meeting at the Parliament and actually told me that she didn't like that we were named publicly, that she was named publicly when we did the call out. And I said, we didn't like that we didn't receive any reply from you. If you replied to us and we had a meeting, maybe none of this would happen. So, but the letter never came to me. And we were like, then you need to look internally and see why you didn't receive the letter that we sent officially to the migration. So sometimes it is important. I'm not saying that it's something that you always need to do. Like I said before, most of the cases and most of the things that we do, we try to keep them more low profile. But if it comes to that and we have to put it publicly, we will go ahead. Mapping your allies. This is really important. First, you need to start from your team. That's what we do. We talk a lot internally. We have built an internal trust with one another so we can disagree, sometimes heavily. A good family is a family that loves each other. All the members love each other despite their different opinions. And it's not once or twice that we had completely different opinions on specific matters, but discussing with people that you trust within your team polishes the idea, and working together with other people who contribute to your ideas and they mean well can really help and can really make a difference, can also sometimes save you from common mistakes that you would be doing, you would be falling into if you were alone. So you need to build an internal team that you trust and build these good channels of communication. before you go externally. And then the external, which is the outer cycle, is start from the people, the partners, the organizations, the networks that can be allies, that are friendly to you. In the case, for example, of the PrEP, we would not ask from the church in Cyprus to support this. There would be no point. We would have to convince them, but chances are they would not be convinced. So we just did not go there at all. We mapped first the NGOs that would be supporting us, and it would be easier to support us. The partners, the allies, the community organizations and groups that would be close, that are closer to us, they already work with us. Some of them said, we support you, but we cannot say that publicly, for example, for different occasions. Some of them said, yes, put our logo there and we are beside you. The same thing goes for the even outer circle beyond the NGOs and the community organizations and groups and allies. It goes into the professionals, the journalists, the politicians, the academia. You need to identify who are friendlier than others, who you can work with, who represent not only ideas that are closer to your principles, but also speak publicly about them and partner with them. And of course, be open to partner with anybody who supports your ideas and your positions. But for any sake, there is no point having allies of the right-wing, the far right-wing, parties or political parties or groups, because they are completely against with everything that we do and we believe. So we should focus and put our energy in those who are supporting us. And in order to do so, and in order to be able to grow this kind of collaborations and have these relationships that you can turn to when you need visibility. For example, you saw all these publications that we did with local media, with portals and with TV stations. We did send it to everybody, but we did do follow-up calls to the journalists and the media that were closer to us, and we have closer collaborations, and they would definitely help us with that if we told them that this is important, we need your help. So yes, we put it out there to everybody, to all the journalists and all the media, but we did some extra work when it came to allies. Communication is really, really important. The last thing that I want to say is the importance of the network. We're here because Africa Advocacy Foundation is organizing this series of events, and we are part of a network, of the My Health network, and with other networks, it's really important to turn to the networks. Sometimes the networks cannot do much in the sense of, providing funding, for example, or do something in terms of the local context, but they can support verbally and endorse what you're doing if you reach out to them. And in those of us where international opinions matter internally, then reaching out to our allies on an international level is really important. Firstly, because you feel that you are not alone. And secondly, because you can really get some more information, some knowledge, best practices, previous researches or previous data that you didn't know about. It's really important to be able to drop an email and ask for a Zoom call for a 5-minute discussion in terms of, we have this and we need your help. We are thinking about doing that. What do you think? What are your suggestions? You are going to be the final decision maker at the end if you are leading this local advocacy, but it's really important to get the knowledge, the collective knowledge that exists outside your smaller circle. So I've put together 12 points for the advocacy kit that you're going to have when you download this presentation, when it's made available. The first one is unpacking power structures. You need to be able to know who is influencing decisions, who is the decision maker, where information is coming from in terms of actually somebody giving a decision that it will be implemented. It's not enough to have allies in a position that are, like what you do and support what you do, but they are not decision makers. You need to identify the decision makers and understand the power structures. In terms of, is there a question? I'm almost done. There are 2 more slides and we are done, and we can discuss for about an hour. So the second, is there a question? Shall I stop or?
Hi, Ibado Elmi. Do you have a question or a comment?
It's okay. It's 5 more minutes and we'll jump into the plenary to have the full discussion. So the second part, the second thing is to pattern, to spot the patterns that exist out there, see how other people have managed them, and learn from recurrent patterns. You don't need to reinvent the wheel. You just need to adjust it to your needs. Evidence-based information, which is point 3, is really important. Get your numbers right. Get legitimate sources. Use them in the arguments. Even get the numbers and the evidence-based arguments that the other side is using. Know about it. Understand if the point that is made by a counter argument is valid. See if you agree with that, and if not, why. And you need to find ways to address these counter arguments with evidence. And then the narrative framing. It's really important for us to understand that the way that we use language is really important. I think in the scope of working with migrant populations, we all know how the narratives are used by specific political parties and groups that are against migration, how they use the wording, and it's important to be prepared for it, to use the correct language, and if needed, to address the narrative, but also the storytelling part of the narrative. An example with the migrant deportation case study was that we didn't really like the fact that we had to use the U equals U as an argument, because we internally felt that people who have a detectable viral load should also be allowed to study, just like European Union citizens who are students and could study, and they even HIV test is found positive, for example, of an EU citizen studying in Cyprus. That would not be a problem if they were, if the virus was transmittable. So we didn't like the second level of discrimination between people who are detectable and people who are undetectable. And the way to handle it was that we recognize that it's a very strong argument in the language that the state understands, in the language that is used within the public health arguments, let's say. So we used it, but we decided to actually put that discrimination out there. And when we were talking to the media, we did point out that, this student is undetectable, thus untransmittable. But even if he wasn't, that should not be, the deportation should not be the case. So sometimes you need to shape the narratives in a way that is really helping you to make a point Now, the fifth part is the rights-based analysis, to understanding how policy, how language works in legal documents, in legal applications, what the law says, how you work around it. And, you know, the step after these two cases, especially the one with the migrant that was successful in 2022, we are at end of 2025, and the legislation has not changed yet. And this is the second point that we put for discussion at the National AIDS Committee is this, after PrEP, that we need to discuss about legal reform. So you need to have not only say that you are right-based, you have an activity in terms of human rights, but also understand how these work in terms of policy and legislation. Stakeholder mapping is what I explained before, of doing a hierarchy of where to find your allies and how to reach out to them, and who not to reach out to. Don't spend time. Don't waste time trying to reach out the people who are already negative and you would take a lifetime to change their opinion. Invest time in those that can help you and that are already closer to your activities. The strategy design is important, to put it together and know that you might need to change it. Coalition building, it has to do with the network of other organizations and groups that can help you, especially with migrant organizations. Something that we see is that, especially if the organizations are migrant-led, it's really important to have, because of these privileges in the countries that we have, we need to use it in our advantage. So we need to partner with organizations that are active in maybe slightly different topics than us, but have the same principles and or similar principles, or they are closer to us. And this could make all the change, especially locally, but not only. And then there is the risk assessment, really important to know what is the worst case scenario, what could be the worst thing, and get prepared for it. Find ways to try to avoid it, but get prepared that it could be the case. And the communication also, it's really important to be able to create these channels of communication with specific journalists and media that are closer to you. I have to say that even the media that are not so close to you, sometimes, sometimes they adopt language that is not what you want, or is hostile, or is putting out narratives that are different. In terms of media, sometimes it is important to not let that pass by. Sometimes it is important, if you identify that there are professionals in that medium that you can have a discussion, then you could try and bring some change in terms of that. But I would not go to hostile media to build these relationships to start with. I would build this with journalists and media and communities that are already friendly, and then try to change the ones that are, let's say, neutral or slightly leaning towards away from your principles. Then monitoring and adapting, you need to put down a process so you can track the progress, evaluate it, see what's not going well, and go back to the strategy and adapt it again. Things change, conditions change, and sometimes for good. But if you are not monitoring change, then you're not going to be able to even see that. And the last is the reflexive practice, which is understanding also your own biases and understanding that we all have, we from one point or another, we all have blind spots. We all have things that work internally, and in our inner self there are stereotypes and things that you need to identify in order to change. So remember that you're not perfect and that you can always improve. So the last slide is that it may take longer, but don't give up. So thank you very much. Let's go into the discussion. I think we have something like 45 minutes. Are you all here?
Thank you so much, Christos. I think this is time for questions. Oksana, thank you for joining us. You just joined us just in time for a discussion and questions. Any comments that anyone may have, I will let Christos, you can be able to see the screen right now. Do you want me to take hands, or you can just continue so that it flows?
I mean, let's take hands instead in terms of taking terms. But let's start with: are there any questions, any specific questions? Like I said before, I'm not coming from a place of an expert in terms of advocacy. I'm coming from a place of experience. Let's say we put out some campaigns. Some of them turned successful. The ones I presented were successful. Some of them were not. And some of them, we hope that they will be successful, but they are not yet. So do you have any questions in terms of how we worked? Anything you didn't, that was not clear maybe, that I could shed some more light on? Please feel free.
Or any additions?
Yes. And also, I would also like people to share their own experiences if they have examples, and we can, in a way, contribute to the work that that is being done already in any way. I think we have someone.
Luiano, I'm so sorry if I pronounced your name wrongly.
Sorry, I delayed, but I had some problem. No, just I want to, because I heard about Alliance. No, I agree with this very much. We have at the moment, we created a network between us and a gay association, an association for gender violence, and another, we have 4. The last one is a psychologist. They deal with the different sexual desire of people. So we do network even for advocacy together. And that is something very helpful for us. Just our experience. Thanks.
Luiano, can you share some examples, some practical examples maybe of how,
for example, the lawyer of each association, when we have a case, they work together. So they have different point of view of the problem. So this facilitate us in going forward to understand how is better. What you said at the end, no, monitoring, because we have different point of view. We are mainly medical. We deal with the health of the people, and the other they deal with the stigma, imagination, or whatever. So we put together all so it make us more, give us more strength when you go forward with the trial.
Yes, it's really important. I have to say that we don't have a lawyer in our team. And that's difficult because not only in terms of knowledge, lack of knowledge. So every time we need to consult someone to understand better what the law says and how it is also implemented, because sometimes the law says one thing and it's implemented in a different way. But it's a good idea to find a way to have a lawyer in our team and in your team, I think. Yeah. Thank you, Luciano. Luciano, grazie.
Ciao, ciao.
Anyone else? Hala. And Hala, yeah.
Hi, everyone, and thank you so much, Christos. Thank you for such an excellent presentation. And congratulations to you and your team on making the PrEP success in Cyprus. I know some of your team. By the way, I'm working with Africa Advocacy Foundation. I work with some of your team. So yeah, it's a huge step for public health and for our communities, and it's a powerful example of how sustained advocacy can create real change. So I have just a quick question about PrEP. If it's currently available for migrants and also undocumented migrants, and what is the situation with PrEP, if it's accessible for everyone, including undocumented population?
So I'll give you first the official answer and then the practical answer. Okay.
Yeah.
Because they're slightly different. So the official answer in terms of PrEP is that it is accessible through, we are in the first phase of the implementation. So it's accessible through 2 hospitals, one in Larnaca and one in Nicosia. So it's not accessible in Limassol, Paphos, or Famagusta yet. Somebody to be able to access PrEP, they need to call a number, book an appointment, go on the day and time of the appointment at the hospital, register at the entrance without having, they could have any kind of an identifier, a passport, an ID, driving license, anything that identifies them. Because the service is free, the minister has to justify, the clinic basically and the doctor has to justify the cost to the ministry. So they need to have a way to monitor who is taking the tests and the treatment, and to make sure that the person who is being treated and monitored and has the treatment is the same person that is actually going every 3 months to get tested. Once they go and they registered without paying anything, they go to the doctor, which is they get the information of the specific, let's say, room in the hospital that the doctor is providing the sessions, and then they go and give blood for the tests. They get the treatment immediately, the same time, for 3 months. So it's pills, it's oral PrEP for 3 months, and then they go again back 3 months after that, maybe a week before the 3 months conclude, so they can repeat the same process of getting treatment for another 3 months, giving blood for the tests, and talking to the doctor in terms of, if they need anything else. So this is the official process. Now, there are problems because a lot of people who don't feel comfortable going to the hospital would not go to the hospital if they have to register at a counter with someone who could be, I'm not saying they are, but there is, I'm not saying they are hostile. Sometimes they are not friendly. There is a slight difference. So sometimes, people are just professional, or people are passive aggressive. So a lot of people who need PrEP would not go by themselves, especially if they belong to specific populations, especially if they are undocumented migrants, for example. So what we are doing is that although they have the access, they can actually go and register and have access to PrEP. I mean, practically they could, because the data that they are giving for the registration are only kept locally for the doctor to monitor. They are not going on the national health system, and they are not, and they should not be connected to any kind of migration services of the police or anything. Nonetheless, we know that this is a problem. I mean, imagine somebody not speaking the language very well, trying to speak, or speaking English but not speaking very well. First, they need to go through the telephone appointment. Then they need to go there and talk to the administrator at the counter for the registration, and then see the doctor. The good aspects of the system is that we have really good doctors that are really working with us for a couple of years now, and their approach is really friendly, really community friendly, and I would dare to say that the specific doctors that we have now in both hospitals are quite professional and good with different key populations. But in order to reach the doctor, the obstacles are there. So I'm going into what do we do practically. We are putting out there that people can come to us first, have an anonymous session. Our sessions are anonymous, so they don't need to provide any information. We can inform them of how the system works, what they need to do to get access to PrEP. They can also test at the PrEP point. So we are doing the testing that we do at the checkpoint. We do them on the day that we offer the PrEP consultation, if the client wants to. And we offer to accompany them for their first meeting, so we can show them around and help them on how to register, on where to go, where they will find the doctor, what's the process, and what to expect in 3 months. And we also offer an open line of communication in between now and in 3 months. So when they take the treatment, if somebody faces any obstacles, like they skipped a day, or they have some side effects that they are worrying about, or anything really, it's more difficult to reach the doctor. You have to wait for 3 more months to see the doctor at the appointment that you are booking to repeat the process. So we are kind of filling that gap, and we made sure that this would operate like that by making a meeting with the ministry and explaining to them that if you want, the data says in all the countries that the PrEP is accessible, it says that the biggest challenge is for migrants to have access to the services. And I'm talking about not only undocumented migrants, I'm talking about migrants who live here, work here. It's harder for migrants to visit a hospital. And it's not only harder for migrants, it's also harder for some gay men who want to remain, or bi men, or men who have sex with men, queer people who want to visit hospitals, and they feel that this is a not very friendly environment for them. And especially for people who engage in chemsex is quite difficult as well for other reasons. So in this consultation that we have with them, we kind of build trust through the anonymity that we can offer them. And we want them to know that they can reach out to us if they need to, or when they need to. And in that way, we're trying to facilitate it, basically, the access to PrEP for those people who would not go by themselves. The service runs since October, and now we are almost mid-December. And I have to say that the people who need our support and our not information, but to accompany them, which is extra effort, extra time. they are not that many. I'm saying that in the sense that, compared to the number of people who have already registered to have access to PrEP, as always, the vulnerable populations and our communities, and we are not the majority. So we are basically, it's easier for us to facilitate that for those people that need us more than others. And we managed through the years to have a good collaboration with doctors as well. So we had a case, for example, of someone who was engaged in chemsex, and a case of a migrant who was undocumented that we accompanied. And the doctor knew beforehand that, I'm coming together with a client who has these characteristics, and I'm telling you so that it needs some more attention. For example, you could speak to the person at the counter and tell them that, somebody from the movement is bringing someone, please help them in terms of, accept any kind of paper they have to identify who they are, for example. If they didn't do that, then you have cases where the person at the counter would insist to have a passport, for example, or a green card, or a yellow slip, or whatever. So sometimes you need to facilitate the access for specific cases in different ways. And I personally think, for those who might think, okay, how are you doing this in terms of cost and in terms of hours? First of all, let me say that as principle, we do a lot of volunteer work. So a lot of the things that we do, there is no actual funding attached to it. But secondly, it's something that I found out the hard way. I could say that if you do it well and you document it in a way, you can get funding for it after you've done it and you've shown that this is a necessity. So if you're anyway doing the volunteer work, find ways to document it. Have some data. How many people did you connect? What characteristics? You don't need to have data in terms of, identifiable data, but you need to have some community data. How many people did call the line that we have for information? So in a year or in 6 months, we can go to the ministry, or to any pharma company and ask for funding to make this a funded service. But in the beginning, a lot of it is unfunded and volunteer. PEP was already accessible in Cyprus from beforehand. It's again not anonymous like PrEP in the same manner, let's say, but it is free. The problem for PEP is that it is only accessible from one point in the south area, only from the Larnaca hospital. So anybody who needs PEP, they need to drive or take the transportation and go to Larnaca to get it. Sometimes it's 1 or 2 hours away from you, which is a lot for the distances in an island where, in a city, anywhere you go, it's within, 15 to 20 minutes, you go anywhere in your city. So, 1 or 2 hours is a lot. And I think that after PrEP is implemented and we see how it works around the different locations and districts, the second step could be to advocate for PEP to be made available at all these points that PrEP is working at, that is being available at. So we have work to do.
Yeah, thank you so much. Thank you so much, Christos. Just for PEP, because we are working on a policy mapping and to see the gaps between the European countries. And for Cyprus, we found that PEP was available for migrant, but not for undocumented migrants. And yeah, that's why I wanted just to check with you because you are there in the field. Thank you so much.
Can I just say that for undocumented migrants, we have to find a way, and this is a call out to AAF and also to other organizations. We have to find a way to inform migrants that, especially undocumented migrants, that they should come to us before they go to the hospital or before they go to the to any kind of this kind of emergency services, because we can do it faster and in an easier way. I understand that PEP is something that works only within 72 hours, and the earlier you start it, the better. But most of the times people don't know about it, and if they do know about it, I don't think that they would really find ways to commute for an hour and get 2 or 3 buses to get to Larnaca. So I think it's really important that they know that the community organizations, not only us, but community organizations can actually help in these kind of situations. And we had cases where we drove the person there, or cases where the person could go by themselves, but we called the clinic to tell them that we are sending somebody, and you need to take good care of them because they are one of our team or something, with a reference, let's say. Unfortunately, this should not be the case. The treatment should be equal and equitable to everybody, but realistically it's not. So we need to make, at least for the cases that there is emergency, we need to make the system friendlier until we change it.
Yeah, good point. Thank you so much.
Any other questions, or anybody who wants to share anything from their own experience?
Good afternoon, everyone, and thank you so much, Christos, with clear speaking language. Your English is very clear for all of us.
Oh, thank you.
I'm John Paul Ngueya. I'm the founder president of Youth of the War in Action, based in Paris. But I've worked long time, since 20 years, with Africa Avenir, Africa Future. Is an organization here in Paris doing preventative action among migrants from Sub-Saharan African and Caribbean. So we have 2-unit mobile car that moving around Paris and region, and make sure that people who are going back from the entry of metro station, coming at the market, just stop and get free test for HIV and hepatitis. So when we are trying to offer them those screening free tests, we try to see in our document. So we have a questionnaire that where you are trying to ask. If we see that you are a person who taking some risk, we'll try to propose you the PrEP. But we cannot just say PrEP is the best one to the condom. We will just say PrEP is a good,